Anesthesia for non-cardiac surgery in children with congenital heart disease. With improved outcomes for congenital heart disease, there is an expected annual increase in the number of patients, anywhere between 10 to 30,000 patients annually. More than 85% of these patients will survive into adulthood and will likely need anesthesia for non-cardiac surgery. The operative mortality is greater than in procedures for otherwise healthy children. And if you consider procedures like pediatric tracheostomy, it may be even greater than the mortality associated with some corrective cardiac procedures themselves. The ASA physical status of 4 or greater is generally thought to be the most accurate predictor of mortality. The risk is greatest in neonates and infants, and other risk factors include emergency operations, poorly compensated patients, and patients referred from tertiary care centers. Poor compensation may be defined as those with congestive heart failure on 2 or more drug therapies, those with pulmonary hypertension or cyanosis. We'll be discussing the classification of congenital heart disease, how to develop an anesthetic plan, and common forms of congenital heart disease and their management. Congenital heart disease is defined as various abnormalities of the heart or great vessels that are present from birth. And it can be classified based on clinical presentation, structure, or physiology. Based on clinical presentation, congenital heart disease can be classified as cyanotic or acyanotic. Shunting of unsaturated blood from the right to the left side of the heart is typically associated with cyanotic congenital heart disease. Pulmonary blood flow is decreased, resulting in cyanosis. Acyanotic heart disease is associated with no or little shunting of blood, or shunting of blood from the left to the right side of the heart and pulmonary circulation. If blood shunts from left to right, then increased pulmonary blood flow will result in pulmonary congestion and congestive heart failure. Defects can also be classified structurally, and this allows for the inclusion of the obstructive class of congenital heart disease. It's important to note that several defects frequently coexist and occur along a spectrum of disease. It's important to note that for right to left shunts, those that are frequently cyanotic may start with the letter T: tetralogy, transposition, truncus, and tricuspid atresia. Classifying by physiology, you can have left to right shunts, resulting in volume overload and CHF. Right to left shunts, resulting in pressure overload, mixing lesions, or obstructive lesions. And, almost forgot that one, regurgitant lesions. For left to right shunts that will result in volume overload and CHF, they can be classified as either intracardiac or extracardiac. Flows across a shunt are often dynamic and frequently determined by the balance of SVR to PVR. Blood will flow from the highest to lowest areas of resistance. In left to right shunts, SVR is greater than PVR, and blood flows into the pulmonary bed, resulting in increased work and pulmonary congestion. As anesthesiologists, we can manipulate flow across a shunt with our anesthetic technique. For example, an anesthetic induction frequently decreases SVR, lessening the flow across a left to right shunt. Now, over time, pulmonary congestion may increase such that flow is reversed, resulting in pulmonary hypertension and Eisenmenger syndrome. But that is late stage. Understanding these diagrams are important to understanding congenital heart disease lesions in the direction of flow. Here you see that for left to right shunts, you have the right side of the heart, then coming back in through the pulmonary veins, the left side of the heart, and out to the aorta. Oxygenated blood flows left to right from areas of higher systemic vascular resistance to lower resistance, which is usually the pulmonary vascular bed. In right to left shunts, blue blood shunts across the right side of the heart to the left side of the heart. Can you give 4 examples of right to left shunt with normal pulmonary blood flow? What about those with decreased pulmonary blood flow? Again, a simple way to remember is that a number of major cyanotic lesions will start with the letter T. Here is a table showing physiology, the effect on pulmonary blood flow, and how decompensation will be characterized. In left to right shunts, in right to left shunts, inhalation induction may take longer, may prolong phase 2, and there may be an increased potential for laryngospasm. Similarly, time to washout is also increased. In right to left shunts, metabolism in the pulmonary circulation is bypassed, resulting in faster IV induction. How may this be relevant? How about IV boluses of local anesthetics? They can frequently exceed the threshold for cardiac toxicity in these lesions. What does repaired mean? Means that there is no impact on the patient's longevity, physical status, or need for further medical care. There are really rarely congenital heart lesions that are truly repaired. There may be a PDA ligation or repair of a secundum ASD in the first decade of life, or repair of VSD in the first year or 2. But congenital heart disease lesions rarely get fixed or repaired. There will always be an associated complication risk that will increase, usually as the patients age. So one must assess cardiac status each time patients present for surgery. Your anesthetic plan will be most influenced by the magnitude of the surgical procedure and the degree of cardiovascular and pulmonary impairment resulting from the congenital heart defect. The degree of cardiovascular impairment is determined by the magnitude of these factors: hypoxemia, cardiac failure, pulmonary disease, and dysrhythmias. Now, cardiac function may appear normal at rest, but the ability to increase cardiac output, or cardiac reserve, is typically reduced in patients with chronic hypoxemia. Hypoxemia-induced myocardial dysfunction also results in myocardial fibrosis with reduced contractility and diastolic compliance at rest, which worsens with increased cardiac output or stress. Hypoxemia stimulates erythropoietin release, and it's one of the most important compensatory mechanisms for oxygen delivery in cyanotic patients. It's important to minimize NPO times to prevent preoperative dehydration because these patients will likely be, to some degree, polycythemic. Patients with chronic hypoxemia also have abnormal hemostasis. They may have normal platelet count, but they will have platelet dysfunction. The most common laboratory abnormalities are abnormal PT and PTT associated with fibrinolysis and hypofibrinogenemia. Cardiac failure occurs when the heart cannot pump enough blood to meet demands. Most children with congenital heart disease, even following repair, are at risk for cardiac failure. Causes of CHF are either an excessive workload on normal myocardium or normal workload on a weakened myocardium. The normal heart may be burdened by both an increase in pressure load and increase in volume workload, or a combination of the two, and each ventricle may be stressed independently of each other. It's important to understand the compensatory mechanisms for ventricular failure. QP to QS is the ratio of pulmonary blood flow to systemic blood flow. It is your cardiac output. A QP to QS of greater than 1 indicates pulmonary flow exceeds systemic flow and defines a left to right shunt. Similarly, a QP to QS of less than 1:1 indicates a net right to left shunt. When QP to QS is greater than 2, symptoms of CHF are apparent. Children with congenital heart disease may have associated airway anomalies. Because of these or other factors, they may be predisposed to pulmonary disease. Some lesions of congenital heart disease are associated with a short trachea. The carina may be 2 to 3 vertebral segments more cephalad. You need to be careful of a mainstem intubation. Associated vascular rings or compression by enlarged cardiovascular structures may cause tracheal stenosis. And pulmonary hypertension may result in enlarged pulmonary arteries, which impinge upon small airways, and that is of greatest clinical concern in infants. Intraoperative arrhythmias can lead to hemodynamic deterioration or even sudden death. The anesthesiologist must be aware of which patients are at risk of developing arrhythmias, what type of arrhythmias are likely to occur, and the most effective treatment. The majority of our SVT is secondary to a reentry phenomenon. Note that 25% of children with Wolff-Parkinson-White may have a normal EKG. Ebstein's anomaly is basically a displacement of the tricuspid valve into the body of the right ventricle. It's the most common congenital malformation of the tricuspid valve and results in a malformed or malfunctioning RV, possibly LV. There is a great variability in the age of presentation, but if not repaired, atrial tachyarrhythmias become increasingly common and result in sudden death in someone who may have not had a diagnosis of the lesion prior to presentation. Here is a picture. Displaced tricuspid valve, enlarged right atrium. Frequently, arrhythmias occur as a result of congenital heart surgery. If there is manipulation or repair near the area of conduction. Some arrhythmias may occur early following repair and may resolve without therapy. Others may require permanent treatment or lifelong treatment, such as with medical therapy or a pacemaker. They may also appear late, sometimes decades after the congenital heart repair, and be asymptomatic or provoke sudden cardiac death. The presence of persistent hemodynamic abnormalities, such as that occurs with single ventricle repairs, like the Fontan, predispose to the development of later ventricular arrhythmias. And arrhythmias are the leading cause of death in patients with single ventricular lesions. Here are some good questions to ask when assessing the degree of heart failure and cyanosis. Hypoxemic children are usually small for age, and in children, heart failure may present as poor feeding and either poor weight gain or increased weight gain. Sympathetic stimulation may result in sweating. In older children, heart failure may present as tachycardia, tachypnea, dyspnea, reduced exercise tolerance, and cool extremities. Note that in cyanotic children, adequate pre-medication may prevent hypercyanosis or cyanotic spells. The importance of the history and physical exam cannot be underestimated. Remember, cardiac congenital anomalies may predispose to pulmonary anomalies, which may be associated with difficult intubation. Calcium and immunologic deficiencies may be seen, especially in children with aortic arch abnormalities. And several electrolyte abnormalities may be present as a result of diuretics. Consider obtaining a chest X-ray with any new onset cardiac or lower respiratory symptoms. An echo will provide a non-invasive assessment of cardiac chamber size, valve function, shunt presence, and ventricular function. Cardiac catheterization is usually only necessary if an echo is equivocal or in older patients with complex anatomy or in patients following heart transplant. When performing a physical exam, listen for your murmurs. Listen to your heart first, but don't attempt to further upset a crying child. You just won't hear much, or you won't hear what you need to hear. Consider palpating the liver or obtaining spot pulse oximeter checks and blood pressure readings in both the upper and lower extremities. What type of 3 murmurs are always pathologic? Your pansystolic, diastolic, and murmurs that radiate. Here are some commonly heard innocent murmurs. Here are some syndromes commonly associated with congenital heart disease that result in airway issues. Trisomy of which 3 chromosomes are associated with congenital heart disease? Be sure to review the charge association. It's frequently tested on written and oral board exams. The question usually arises as a small patient, a neonate, presenting for choanal atresia repair, or an older infant or child presenting for coloboma repair. Again, don't underestimate the importance of history and physical exam. You don't want to get stuck in the mud and not be able to get out. In 2007, the American Heart Association released updated guidelines for endocarditis prophylaxis in children with congenital heart disease. They recommend for the following conditions preoperative antibiotics: those with a history of bacterial endocarditis, those with palliative shunts and conduits not having reached completion stage of repair, and completely repaired congenital heart disease patients only within the first 6 months after the procedure, as long as there are no residual defects. Procedures for which prophylaxis is recommended will include dental procedures with manipulation of tissue, respiratory tract procedures like tonsil and adenoidectomy, but only GI and GU procedures if there is infection. The most commonly found organisms that cause bacterial endocarditis include staph, strep, and enterococcus. And our treatment for bacterial endocarditis is commonly IV antibiotics for 6 weeks. Some patients with palliated congenital heart disease will be on lifelong aspirin, including those with systemic to PA shunts and Kawasaki disease. Stopping aspirin therapy in patients with systemic to PA shunts may not be feasible. Frequently, we may avoid nasotracheal tubes in these patients and have a discussion with the patient's cardiologist and surgeon to determine if they can be stopped for a reduced amount of time, such as 3 or 5 days, as opposed to 7. For emergency non-cardiac surgery, rapid reversal will only be possible with replacement of coagulation factors, and typically we start with FFP. Remember that vitamin K will not be immediately effective and typically takes 24 to 48 hours. When planning for intraoperative monitoring, we consider leads 2 and 5 to be our most accurate indicators to detect ischemia. TEE may be useful for major cases like spinal fusion, and it's commonly thought that they're more useful than central venous catheters in assessing preload. But you have to understand cardiac physiology prior to placement for both successful placement and correct interpretation. Ventilation in the cyanotic patient has important considerations, including that positive pressure ventilation may result in an increase in dead space, and end-tidal CO2 measurements will underestimate your arterial CO2 readings. Cyanotic children with reasonable cardiac function are routinely anesthetized with an inhalational agent, although it's important to remember the effects of inhalational agents on the cardiac system because they will be accentuated in our children with congenital heart disease or cyanotic lesions. Nitrous oxide decreases cardiac output to some degree. The data regarding nitrous oxide is conflicting, but as it definitely enlarges air emboli, it is best to avoid in patients with shunt defects. Ketamine is a great IV induction agent in sick children, but its action is dependent on the release of catecholamines. So it may in fact act as a negative inotrope in catecholamine depleted patients. In those patients, etomidate remains your safest IV induction agent. Propofol may cause decrease in oxygen saturation for those patients with systemic to PA shunts, like BT shunts, as those patients are dependent on pulmonary blood flow from the systemic circulation. Here are some other good pearls to consider for induction or maintenance of anesthetic. We frequently avoid classic neuromuscular reversal agents like glycopyrrolate and neostigmine following orthotopic heart transplant.